This meeting is being recorded.
Okay, presenters, you may start.
Okay. A very good day to everyone. Today we would like to present about the emerging infections in Malaysia, control and surveillance. These are the group members. Okay. Firstly, we are going to look into the Nipah virus. Okay. What is emerging diseases? Emerging diseases or emerging infectious diseases are diseases that newly appear in population that are never before recognized in humans or existed before but are rapidly increasing in incidence, which means number of cases, geographic spread, or both. They may be caused by a completely new pathogen or a known pathogen that has spread to new populations or regions. It is also caused by a previously recognized agent whose role in disease was not recognized or a re-emergence of a pathogen, for example, due to antimicrobial resistance or breakdown in control measures.
Okay, so I will now continue with origin and history of Nipah virus. So it is firstly recognized in 1998 to 1999. It is an outbreak among pigs in Peninsular Malaysia, such as Perak, Negeri Sembilan, and Selangor. In 1990s, rapid deforestation and El Nino drought causing the decrease in forest fruiting. Bats traveled closer to farms to feed on cultivated fruit trees. Malaysian pig farms often planted fruit trees around the enclosures, attracting bats. Pigs are amplifying hosts. Fruit bats, genus Pteropus, are natural reservoir. They shed the virus through urine, saliva, and partially eaten fruits. Subsequently, nearly annual outbreaks have occurred in Bangladesh and sporadically in India.
So for global and national trends and disease epicenters, for global trends, it is classified as WHO priority pathogen due to high fatality, which is 40 to 75%, and potential for epidemics and no specific treatment or vaccine. And most cases occur in South and Southeast Asia. Increased frequency of outbreaks in Bangladesh and India indicates heightened spillover risk. For national trends, after the 1998 to 1999 outbreak, there is no major recurrence due to strong control measure such as pig farm surveillance, zoning and surveillance, continuous monitoring of bat population and pigs by of Health and Department of Veterinary Services. Malaysia remain at risk, especially in areas overlapping bat habitats or with pig farming activities. For global epicenters, Bangladesh is the main hotspot with seasonal outbreaks, and India, Kerala is a high-risk area with repeated outbreaks. And for Malaysia, historical epicenter but control since pig farm restructuring, and potential resurgence such as country with Pteropus bat population, such as Cambodia, Indonesia, Thailand, Philippines, and also Australia.
Okay, for the next part, which is the factors contributing to the spread of the disease. The first one is close contact with infected animal. Nipah virus is a zoonotic disease. Primarily spillover occurs from fruit bats, like Pteropus species, natural reservoir. Pigs amplify the virus and pass it to human. People who handle pigs or live near bat habitats are at higher risk. The second one is consumption of bat contaminated food. It is a major route in Malaysia and Bangladesh. Raw dead palm sap contaminated by bat urine or saliva. Fruits partially eaten by bats. This allows direct transmission from bats to human. So the third factor is close contact with infected human. Human to human transmission can occur through respiratory droplets, saliva, urine, blood, contact with contaminated surface, and caring for sickness patients without PPE. The fourth factor is poor infection control in healthcare settings. Nosocomial spread is common when PPE is inadequate, poor hand hygiene, shared medical equipment, and overcrowded wards. This was a key factor during outbreak in Bangladesh and India. Slide. So the fifth factor is high density of animal farming, especially pig farms located near fruit orchards, which encourages bad pig-human transmission cycle. This contributed significantly to the 1998 to 1999 Malaysia outbreak. The sixth factor, which is the final factor, is the environmental and ecological changes. Deforestation and land use changes push fruit beds closer to human settlement, increase bed feeding in orchards or farm, and increase human to animal contact. This increases the chance of spillover. The seventh factor is movement of livestock. Transport or infected pigs can spread the virus across region or states as happened during Malaysia outbreak. The eighth factor is cultural and behavioral practices. Drinking raw dead palm sack, handling sick animals without protection, and using contaminated fruit in markets. This behavior increase exposure risk. And the ninth factor is limited public awareness. People unaware of symptoms, how the virus spreads, and proper prevention methods can lead to delayed reporting and continued transmission.
Okay, now I'm going to present about the surveillance and control measure to combat Nipah infections at Malaysia. So there are several effective ways. Which is the first one is to alert healthcare workers, mandatory reporting of all human cases with acute encephalitis or severe respiratory illness. Second is to monitor pigs, continuous testing and monitoring of pig populations at the farms and abattoirs. And the third one is to track bats, regular testing of bats in high risk zones near humans or animal habitats. For control policies, the first one is biosecurity rules, policies mandating farmers to bat-proof pig sheds and protect feed or water from bat droppings. Second one is ban animal movement, strict policy enforcement to stop the unauthorized transport of pigs from infected zones. And the third one is public campaign, continuous campaign to educate communities to avoid contact with bats, sick animals, and contaminated foods. And then this is the surveillance and control measure to combat Nipah infections at WHO level. So for surveillance, the first one is standardized definition, global standards for identifying and reporting suspected Nipah cases in human and animal. Second one is boost lab testing, programs to help countries build capacity for quick and safe lab diagnosis. For example, RT-PCR and rapid response using GOARN network to quickly send international experts to help countries manage outbreaks. For control policies at WHO level, the first one is Healthcare IPC. It is a guideline for strict infection prevention and control in hospitals to prevent human to human spread. Second one is a risk communication. Develop public safety message tailored to local risk. For example, avoiding raw dead palm sap in South Asia and washing or peeling fruits. And the last one is One Health mandate. Advocate for a formal multi-sectoral policy ensuring veterinary, public health, and environment agencies work together on NIV preventions and response.
Okay, next we will focus on coronavirus. Coronavirus are a large family of enveloped, single-stranded RNA viruses that commonly infect both humans and animals. These viruses belong to the family Coronaviridae and the order Nidovirales. There are several notable diseases caused by coronavirus. First, MERS, which stands for Middle East Respiratory Syndrome, is caused by the MERS-CoV virus. Next, SARS, or Severe Acute Respiratory Syndrome, is caused by the SARS-CoV virus. And finally, the disease we are most familiar with, COVID-19, is caused by SARS-CoV-2, another member of the coronavirus family.
Now we will discuss the origin and history of coronavirus. For SARS, the coronavirus is first identified in November 2002 in Guangdong Province, China. It is caused by SCoV and now called SARS-CoV-1. It is likely originated in bats, and the outbreak was brought under control by mid-2003, and WHO declared SARS contained by July 2003. Next is MERS. It is first identified in 2012 in Saudi Arabia. It is caused by MERS-CoV. MERS has fewer cases compared to SARS and COVID-19, but it is very deadly and has a high fatality rate of about 34%. Bats are the likely original reservoir of MERS, and MERS hasn't caused a large global pandemic, but sporadic outbreaks continue, particularly in the Middle East. For COVID-19, the first case is reported in Wuhan, China, around December 2019. The virus was initially called 2019 nCoV, later named SARS-CoV-2, while the disease is called COVID-19. Genomic studies suggest it's closely related to bat coronaviruses, supporting a bat reservoir. It is declared a public health emergency by WHO on 30 January 2020 and declared a pandemic by WHO on 11 March 2020. COVID-19 has caused a massive global outbreak with millions of infections and deaths.
Next, we'll move on to the epidemiology of COVID-19. For the national trend, as of May 31, 2025, Malaysia has a total of 5,346,653 COVID-19 cases, with 228 daily cases, 316 daily cases with 55 positivity rate. In daily hospital administration include 36 patients. There is only one patient admitted to ICU and there is no reported death. For global trends, since mid-February 2025, there has been a rise in global COVID-19 activity based on the data from Sentinel surveillance site. The test positivity rate reached 11% in May 2025 across 73 reporting countries, level similar to a peak seen in July 2024. And the increase is mainly seen in Eastern Mediterranean, Southeast Asia, and Western Pacific region. For the disease epicenter, through the COVID-19 pandemic, its epicenter shift over time with each wave. First wave is in Wuhan, China in late 2019 to early 2020, where Wuhan, China is the first known cluster of pneumonia cases caused by SARS-CoV-2, considered the initial global epicenter. Next is switch to Europe, especially Italy and Spain around March to April 2020, where there is rapid spread, overwhelmed the healthcare system. When northern Italy become the European epicenter, then it spread to Spain, UK, and France. Next, it goes to United States around mid 2020 and onward, where it become the world's largest contributor to cases and death, where specific epicenter shift within the US. First in New York at the early 2020, then it goes to southern and western state. Next, it's go to India in early to mid 2021. There is Delta variants. India became the global epicenter during the explosive Delta wave, and it has extremely high case number and mortality. Fifth one is Brazil and South America during 2020 to 2021, with sustained widespread transmission, where the P1 Gamma variant from Manaus made Brazil a major epicenter. Lastly is South America, and it has a lot of multiple period where it is K epicenter during emergence of Beta and later Omicron variants, where the Omicron, which is in late 2021, quickly shift the global epicenter of variant spread.
For factors contributing to the spread of COVID-19, the first factor is respiratory transmission. The virus spreads easily through droplets and aerosols released during coughing, sneezing, talking, or breathing, especially in enclosed or poorly ventilated spaces. Next, close human interaction, crowded places, social gatherings, and failure to maintain physical distancing increase person-to-person transmission. The third factors is poor preventive practices, low mask usage, inadequate hand hygiene, and improper cough etiquette allow the virus to spread more rapidly. The fourth factor is asymptomatic and pre-symptomatic spread. Individuals who are infected but show no symptoms can unknowingly transmit the virus to others. The fifth factor is high population mobility. Domestic and international travel accelerates spread by introducing the virus into new areas. Last factor is population density. Urban, crowded living environments facilitate rapid viral transmission among large groups of peoples. Next, I'll continue with surveillance and control measure of coronavirus. For Malaysia level, the government enforced MCOs targeted mass screenings, SOPs for public places, and community engagement programs to control spread. Isolation and quarantine of cases and close contacts, supported by legal enforcement, play a critical role in breaking transmission chains. For WHO levels, WHO recommends integrated surveillance systems combining routine reporting with event-based and laboratory surveillance to detect emerging infections early. WHO supports countries by providing technical assistance to develop and implement local IPC policies and guidelines, conducting in-country assessments, and offering ongoing training and support for healthcare workers. This includes the global annual Save Lives, Clean Your Hands campaign. That's all from us. Thank you.
So that is all for our presentation. Thank you.